Good morning to all. So I will be presenting for RUCAM versus RECAM. So I will be covering this topic under the types of DILI and drug responsible for drug-induced liver injury, risk factors for DILI, patterns of DILI, RUCAM score and its limitations, and why we needed to develop a RECAM score, which is a revised electronically based causality assessment method. Domains of RECAM score, advantages, limitations, and future directions. So, as we already know, types of DILI, we categorize them to intrinsic DILI and idiosyncratic DILI. Intrinsic DILI is due to the properties of the drug. It is a dose-dependent, highly reproducible, and onset is within a short span of time. Idiosyncratic DILI is at the therapeutic dose. It has a variable latency to onset, and it has immune adaptive system interactions. So drugs responsible for causing intrinsic and idiosyncratic DILI are paracetamol, amiodarone, steroids, antimetabolites, cyclosporin, valproic acid, statins, and idiosyncratic causes includes amoxiclav, allopurinol, bovrone, halothane, and ATT drugs, antifungals. So there are multiple risk factors for development of drug-induced liver injury. There are host factors, environmental factors, and the factors which are drug-related. Age is one of the host factor. At younger age and older age are more risk factor. As the younger age, children develop DILI because of the ATT induced or anti-epileptic drugs. At older age, because of the comorbidities and drug interaction, they develop DILI. Female are more at risk of developing drug-induced liver injury. In pregnancy, it behaves like 30% rule. 30% are at risk, 30% remain stable, and 30% develop severe DILI. Malnutrition, of course, is a risk factor. Obesity, diabetes, and comorbidities. Environmental factors included smoking, alcohol consumption, and infections. And drug-related are like DILI's dose, metabolic profile, class effect, and cross-sensitization. Cross-sensitization is like two drugs developing DILI which has similar chemical structure. And in class effect, there is a narrow therapeutic class like COX-2 inhibitors or HMG coenzyme inhibitor. There are drug interaction and polypharmacy, which includes multiple drug given to a patient and they develop DILI. So patterns of DILI are hepatocellular, cholestatic, and mixed. They are on the basis of R score. The R score, which is basically a ALT divided by ALP. If it is more than 5, it is a hepatocellular. Cholestatic, it is less than 2, and mixed is between 2 to 5. So to assess whether drug has caused the adverse drug reaction, we do a causality assessment. It is a relationship between drug treatment and adverse event development. Whether particular treatment is a cause, and it is also an essential part in the hospital to reporting and pharmacovigilance team guiding assessment. So what are the qualities of a causality assessment method? It should be validate and it should be reproducible. So validity means that it should distinguish between the drug causing DILI and whether the drug is not causing it. And reproducibility means it should cause the same effect if it reintroduced. So there was a score developed, RUCAM score, in 1993, and it has 7 criteria, which included time to onset of drug reaction, course of the reaction after the stoppage of drug, risk factors of drug reaction, which they included are age, pregnancy, and alcohol, which has been omitted in the next RECAM score, concomitant drug administration. In the recent RECAM score, this has been omitted, and RECAM score has been developed for a particular drug, and RECAM score has to be calculated for each and every drug. Whether other non-drug related causes are present or not, like autoimmune hepatitis, hepatitis A, B, C, alcohol causes sepsis induced, and other causes. Previous information of the drug, whether it has caused liver injury or not, has to be was assessed. And response to re-administration, it was a major criteria earlier in 1993, now it has been omitted. So if we see the criteria, then it has included the hepatocellular and cholestatic. It was a major demerit that they included cholestatic and mixed in the same table. and there was a different time of exposure, like in hepatocellular and in cholestatic. There's a different timeline, which was also a major drawback. And after the stoppage of the drug, there was also a another difference timeline, like 30 days in the hepatocellular and 180 days. Risk factors, which were alcohol, age more than 55 years, they have taken risk, and pregnancy, they have been omitted in the recent RECAM score, as they did not find the odds ratio to be high enough to be included in the recent score. Other drugs involvement have been changed to another class, and the competing drugs were also ruled out. Previous drug information about the causing of delay was also looked into and re-challenged. So next, so RUCAM limitations were low inter-rater reliability because of the more of subjective criteria rather than objective criteria. It was a complex, ambiguous instructions, different timelines. There are mixed cases grouped in the cholestatic group, and there were disagreement in calculating time to onset between the hepatocellular group and the cholestatic group. There was arbitrary risk factors like age, alcohol, pregnant. There was no evidence behind it in 1993, so they have, on the basis of expert opinion, they have taken these three criteria. Unclear criteria for the competing drugs in that score, and it relies largely on re-challenge, which is very seldom done in our cases, apart from ATT. So the new score came in 2022 recently. It is a revised electronic causality assessment method. It is updated and computerized based, and it included 98 patients from the Delhi network and 96 patients from the Spanish network, and in each cohort it was evaluated by the three different pathologists in Delhi network, in the US, and Spanish drug registry also. The three experts were played role in assessing the injury. So the 7 criteria was modified to 5 domains, and the 5 domains were time to onset of drug reaction, and time to onset, and after the onset, when it drug was stopped, and what was the timeline when it was decreased, LFT was decreased. De-challenge or normalization or washout. Literature supporting liver injury. Exclusion of competing diagnosis like alcohol, hepatitis A, B, C, and autoimmune diseases, sepsis. Search for other non-drug causes. It domain 5 included the liver biopsy, and liver biopsy was only given 1 merit point in this criteria. So they were classified into 4 groups: highly likely or highly probable, and RUCAM also included the same group: probable, possible, and unlikely or excluded, with the score of less than 2, 5 to 3, 3 to 5, 6 to 8, and more than 9 in RUCAM. So domain 1 included time to onset after start of drug, the reaction, and after the stopping of the drug, what normalization, how it happened. So if the drug reaction occurred in less than 1 day, then it was given -6 points. In -6 points, the drug was withdrawn, and it was considered that drug is not causing delay, and the whole RECAM score has to be stopped, not assessed further. If at 2 to 9 days, and the score was given 3 merit points, 10 to 16 days thereafter, and after the onset after drug stoppage, if it is less than 30 days, it is 0, and if it happened more than 120 days, then it is -6. So -6 is drug is not responsible to cause delay. In de-challenge or recovery after the drug delivery, if the hepatocellular pattern was there, then the score was calculated with the respect of ALT, and if it was cholestatic, then the score was calculated on the basis of ALP and bilirubin. So -6 was given if the drug is still taken, whether greater than 50% of the decline. In domain 3, there was a literature supporting the liver injury, and A, B, C, D, E, and X was given. A and B showed that more than 50% case reports were there to cause delay. C, D, and E included less than 12 to 3 case reports of the previous case reports causing delay, and E was undeterminate, X was not known. So domain 4 included exclusion of competing diagnosis, hepatitis A. What is important is that if the data was missing for hepatitis A, B, then they were given -3 points. That estimation of hepatitis A and sending investigation of hepatitis A, B, C, E was necessary, otherwise they were given -3 points. And thereafter they were given points according to the positivity, whether hepatitis B antigen is positive or antibody is positive. In hepatitis C, RNA is positive or antibody is positive. Alcohol, biliary or parenchymal diseases, autoimmune hepatitis assessment, liver injury or sepsis is related. Last domain, fifth domain was it included retrospective re-challenge and prospective re-challenge. Prospective re-challenge was given 6 points, and it was a maximum point given to in RECAM score, that on re-administration whether the same pattern of liver injury happened or not. Liver biopsy was given 1 point. If other causes were ruled out, then CMV, hepatitis, EBV, HSV were also asked to send, and whether any history of DRESS or SGS was there or not was also assessed. So in this cohort only they included 98 patients in Delhi network, and Spanish registry had 96 patients, and they had older cohort in Spanish registry with the mean age of 58 years, and mostly patients were probable Delhi in Spanish cohort, whereas in the Delhi network there were 39 patients of highly probable Delhi. In this graph also it shows that RECAM score performed better than the RUCAM score in giving highly probable and highly likely incidence of causing drug-induced liver injury. And if we assessed further, then the final result showed that RECAM score has high probability of coefficient of variation of Spearman coefficient of 0.87 as compared to RUCAM 0.85, although it was very narrow, and the percentage agreement was only 62% in RECAM and RUCAM has 58%. It has high sensitivity for 72% for the RECAM, and the unlikely or excluded cases has 97% chances in RECAM and 99% so in RUCAM. So the chances of predicting the delay in RECAM was similar, almost 87% to 85%, and they had more predictability in exclusion rather than in predicting. So advantage of RECAM score has better observed overall agreement at the extreme, like unlikely and highly probable. It's a greater specificity to correct and classify probable cases. It offers scoring with less subjective input, and more objective parameters are there. Automatic warning for data that are inconsistent with delay were not included in the RECAM, where they were part of the RUCAM. In unlikely delay cases, RECAM gives warning to stop with a score of -6. So if the anytime score of -6 is given, then we stop following the RECAM, and drug is labeled as it is not responsible to cause drug-induced liver injury. So RECAM also score has 3 different score within the span of 2 to 90 days, whereas in the RUCAM it has only 1 point given up to 90 days. So limitation of RECAM score are also there. It has long latency. In the patient who is seeking delay seeking in medical health, then the latency period cannot be estimated. If the patient comes at 15 days or 1 month, then we cannot determine that it is a 15-day liver injury or 30-day liver injury. Complete agreement of RECAM score was just 62% as compared to 59% for RUCAM earlier. It is only developed in US and Spanish cohort only. No other cohorts study has been done. It is limited to single agent medication cases, and we have to calculate each score individually for the other medicines also. So if the patient is receiving 4 medicines, then we have to calculate 4 RECAM score for that patient. Agent causing delay only after prolonged latency, 90 days, were not included in this RECAM score. And the RECAM score was also not designed for the herbal drugs supplements. The CAM intake was not also considered in this RECAM score. So it is a easy to use web interface where you put the number when you have started the drug, and then you put the number, and then you go forward with the site, and then they will ask you to put the other information. On the basis of this score ranges from -6 to 20, and more than 8 is for the highly likely and high probable, 7 to 4 to 7 is for probable, -3 to 3 is for possible, and less than -4 for unlikely or excluded delay. Other causality assessment scales are RUCAM, which was already discussed, 1993 it was developed, and in Marian Victorinox system it was developed in 1997. Digestive Disease Week Japan score, they also developed causality assessment method in 2004, and updated RUCAM was in 2015. Now RECAM score has been developed in 2022, but it has only 200 sample size. So future directions are studies to validate in India, Asia and other European countries are needed. Need to include herbal drug supplements or CAM, which are the most common cause of delay in India. Need to incorporate recent causes of delay like immune checkpoint inhibitor, TNF alpha inhibitor, COVID vaccine, T extracts, which are responsible for causing delay. To summarize, RECAM is electronically modified, renamed causality assessment method. It has better inter-rater and intra-rater reliability due to computerized categorical data entry and minimized subjective opinion. Domains include time to onset, D-challenge or recovery, previous history of drug causing liver injury and exclusion of diagnosis. And this score has to be calculated for each drug separately to label as causing drug-induced liver injury. Thank you.